Introduction, and thanks again for inviting me to speak with you all about this. So the strategic approach of PNHP towards accomplishing single payer has evolved a lot in the last few years from where it was when we started, of pointing out the problems that we have in the country and spelling out a possible solution, to now shifting to a much more, I hope, robust and cohesive strategic plan that started actually a year or two ago and extends for a few years into the future. So I'm going to spell that out to you. Let me get my slides up here and show you. So I think you can see things. Yes. Yes. Okay, good. So we're going to, in addition to be talking just sort of about the strategic plan, you're going to notice that a lot of the strategy includes a focus on exposing and hopefully addressing some of the problems that are in the Medicare Advantage, so to speak, program in the country. And I'm going to talk a little bit about Medicare Advantage in the midst of this to help you understand why we think that's an appropriate place to be focused. So that'll be in there, and we'll have all kinds of practical things along the way. So the problem is we have a target-rich environment that's all woven together. If you want to understand how to kind of move things forward, the first thing is to look at what the problems are. And the biggest problem facing American healthcare today is how profiteering and greed are frankly destroying all sorts of parts of healthcare. You can almost, throw a dart at a map of healthcare and find profiteering and greed destroying it, from nursing homes to dialysis to hospice to all, medical groups, all sorts of organizational pieces. It's a huge problem. And so we were trying to figure out, well, how do we approach all of these things? Because they're all related. And we thought, well, you can't really, you can't. So rather than spread our resources as an organization on all of those pieces, which we touch on from time to time, we decided if we really wanted to be effective, we should focus in a place and one specific strand of the spaghetti. And so we kind of looked at the landscape and thought, well, what touches all of that? What's the part that touches all of that? And so we began to focus specifically on Medicare Advantage as a piece. But we had a range of choices. So the traditional approach to getting to single payer, which still might be a part of the answer, is one leap across the chasm. And many have said you can't cross a chasm in two leaps, and I'm not so sure about that. I've hiked the Grand Canyon, and I don't think I could jump across it. I think you have to slowly climb your way down and across and climb your way back up. I think if you want to cross a chasm, I think what you have to do is shoot an arrow with a string on it across, and then build a bridge, and then make a highway, and kind of some one leap across the chasm. There's a lot of failures at the bottom of those chasms when you try to do it in one leap. On the other hand, ultimately it is one leap, and so that is why at some point it's all about getting the single payer bills to pass. And so indeed, you'll see built into our strategy when the bill get resubmitted next year, as they do every 2 years, that part of our strategy, of course, includes fighting for more and more co-sponsors of the bills with the effort to make them more and more popular, viable, and organizing around. So one leap across the chasm, part of the solution, but not really the entire strategy. Then there's the game of whack-a-mole. This is the individual bands of spaghetti, trying to get which one do you focus on, and it's that's really hard to get to focus everywhere. You'll hear, I'm sure, during this internship, you're going to hear about state-based solutions, and there are pros and cons to that approach. Canada started with one province having their national health insurance program, and then other provinces followed. And so there's some thinking that that's the model that we could do here. And it's beyond scope for today to address those pros and cons, because that's a whole discussion, and you're going to have hours on that. But some folks are very passionate about that, and some folks are less passionate about that. And PNHP's position is that we're not smart enough to know if that's the right or the wrong approach. And so, we, as an organization, we make room for people who take that approach. And yet, as an organization, we don't have the resources to focus on 50 plus states. So we focus on the national piece. And there are some who feel strongly on both sides of that debate, from whom you'll be hearing, and we're sort of agnostic about that in terms of taking a position. But there's that set of strategies. Then there's the idea of inch by inch, row by row, strategic incrementalism, and that's something that's got to be done with caution and care, because it's possible to divert yourself for years onto good but non-substantial increments, and then delay the work you need to do. On the other hand, some of the incremental work that you want to accomplish will actually make it easier to get to single payer. And indeed, so any incremental pieces need to be aligned with that end in sight. And indeed, we'll be talking about some of those. And then the last component of how to pick a strategy in this context is just being realistic. How much power do we as an organization have? Do we have enough power to call for the immediate adoption of single? No, of course we don't. So we don't have that kind of power. So instead, think about how to build that. And think about where people in elected officials are on the spectrum, and what messages are things that we can work in common with on them. And we're going to talk about that. So sort of a range of things. I think the answer in part to what strategy should you take is some degree of all of the above. So we're going to unpack quite a bit more about Medicare Advantage in a few minutes, but the first part of our current campaign is to stop the outrageous subsidies that are going to Medicare Advantage. I know you heard a bit about that from Dr. Malik a couple days last week, but stopping those subsidies is an important piece. It's a large piece. Currently, CMS is being rated by Medicare Advantage corporations up to our estimate is $140 billion a year. And we'll unpack that a bit. And the reason this is important is, we're not economists for single payer or for Medicare for a national health plan. We're physicians for a national health program. And the reason we're so focused on the financial part, or have been so focused on it, is because that's just destroying, that's pilfering the funds that we need to do a healthcare program, and we're not getting what they're being paid for. So the subsidy has jeopardized what we want to accomplish. In and of itself, stopping the Medicare Advantage subsidizations is a goal worthy in and of itself. So part of the focus on stopping the subsidizations is that this is a topic that has broad agreement. Conservatives, progressives, most folks are unhappy about squandering money and about wasting money. And most members of Congress, if they're persuaded that this isn't getting value, become upset. And so this topic of stopping the Medicare Advantage subsidies has broader agreement. If we indeed can reverse their subsidizations, then that would slow down the growth, because the people that run Medicare Advantage companies are doing it because it's a very profitable line of business. And so if they weren't able to get these subsidizations and profound overpayments out of the federal government, they would not have the business imperative to focus here. So we think that by itself would have a big impact on the rapidly growing train. And then, of course, we think that those subsidies should be diverted into paying for improving traditional Medicare in a number of ways we're going to talk about. But understand that not everybody who agrees with us about stopping the subsidizations thinks that $140 billion a year, to use our number, not everybody thinks that money should be rediverted into improving traditional Medicare. Many do, not everybody. So I drew the circles like this to show that the group of people that agree about stopping subsidies is a bigger group than the group that says, let's improve traditional Medicare. And then, the idea here being redirect the subsidies. This is so important to do these two strategies of stopping the subsidies and improving traditional Medicare in synchrony, because people are choosing to go into traditional Medicare because they don't really have any choice. I believe Dr. Malik unpacked the issues of Medigap with you. And so, if you go into traditional Medicare and don't purchase Medigap, you're exposing yourself to a 20% coinsurance for all outpatient visits and a $1,600 or $1,700 payment for inpatient hospitalizations. So that can add up. If you go to the doctor once a year, that's not that big of a deal. But if you're sick and you're going to see a physician 2 or 3 times a week, or you get 2 or 3 hospitalizations, traditional Medicare without Medigap can bankrupt you. So 90% of people in traditional Medicare have Medigap, which largely eliminates the copays and co-insurances and deductibles and all that stuff. So if you were to just try to stop the MA subsidies and not improve traditional Medicare, in my mind, you would frankly be hurting a lot of the people that are in Medicare Advantage for clear economic reasons, clear financial reasons. They wouldn't, as modest and limited as the dental benefit that many MA plans offer is, there isn't any dental benefit in traditional Medicare. There's no eyeglass benefit. There's no hearing aid benefit in traditional Medicare. And then there's these unlimited out-of-pocket costs, whereas in Medicare Advantage, there is a limit to how high your out-of-pocket costs can go. By statute, it's about $13,000 per year in and out of network. And in reality, the vast majority of Medicare Advantage plans offer a $5,000 in-network out-of-pocket maximum. There's no parallel to that in traditional Medicare. Those copays, co-insurance, deductible, there's no limit to that. So if you cut down the subsidies and you don't fix in traditional Medicare, you would be forcing folks to go into a program that doesn't have those safety nets and those extra benefits. So we think the strategy of improving traditional Medicare has to go in synchrony with the focus on Medicare Advantage to create, as I said here in this slide, a safe landing pad for people in Medicare Advantage. And we need to know that support for these two pieces, support for stopping the Medicare Advantage subsidies and using that money to improve traditional Medicare, there's people who agree with those things, but who still don't think the idea of single payer is the right thing. They still don't think they want a federally run national health insurance plan. They don't want that. So that's an issue that we need to bear in mind when we're talking about it. But doing these things, improving traditional Medicare in the way that I've outlined here, would frankly simplify the process of implementing single payer. All of the things that we've talked about in improving traditional Medicare that I'm going to unpack a little bit more, all of those things are embedded in Medicare for All, and frankly, in a stronger and more robust and compelling way in Medicare for All. So getting these pieces embedded into traditional Medicare Day would make the transition into single payer easier. But bear in mind that not everybody who agrees with us about stopping the subsidies and improving traditional Medicare, not everybody agrees with the third leg, which is to enact single payer. So just keep that in mind. But the good news is that the work we need to do on those first two circles, the work to reduce Medicare, eliminate hopefully Medicare Advantage's subsidies, and the work to improve traditional Medicare, that's the exact same work that we need to do to get to single payer. So this is, in our mind, a really well constructed strategy. So step one is stopping the subsidies, and you can't get ahead of your skis. We have so much power and not beyond that. So when we started working on the MA subsidies, we thought the most we could hope for doing is exposing the problem, get people aware of the problem, with the goal being to change the national dialogue in this exposing. So I'm going to show you some evidence that we've been succeeding at that. 2 years ago, people were talking about Medicare Advantage subsidies being entirely related to overpayments, upcoding. And it turns out upcoding, which we'll talk about momentarily, upcoding is one of half a dozen ways that these organizations are subsidized, and it's one of the smaller ways that they're subsidized. So with our report and our work, we haven't heard anybody in the last several months say that the Medicare Advantage subsidies are just the $20 billion from upcoding. People have been migrating towards the larger numbers that we and now other organizations have been putting together. So I think that has helped getting people to realize how important it is. But that is where we started, is to expose the problems with profiteering. And that's where our first report, that I hope you've all seen already, came out last year. We decided to focus on the overpayments and the subsidizations, and we're going to unpack that in just a moment. And then our second report, since, as I said before, we're not economists for single payer, we are physicians for single payer. Our second report was focused on the clinical harm that we believe these corporations are inflicting on patients, frankly, on physicians, and even on hospitals. So our second report was focused, that came out just a couple of months ago, on the harm that these outfits are inflicting on us. And then we have two more reports that are getting queued up that are not here yet. Third one, hopefully, will be on the sort of the logical conclusion of the first two, which is, what does this mean for equity? Um, and if so, we'll get to that. But what does this mean for equity when we have disenfranchised communities more likely to go into this inferior insurance product that is Medicare Advantage? So, that needs to be unpacked more, and we will. And then the last, I'm not sure which order they're going to come out in, but we are starting work on another report to looking at the moral injury that corporatization writ large, and certainly Medicare Advantage, is inflicting on physicians and patients. The burnout, the demoralization that we have as physicians when we go to see somebody and we do the hard work and still can't get the insurance company to pay for what patients need, and we see them slipping between our fingers, or we spend this outrageous amount of time getting approvals. That hurts us, and it accumulates, and it hurts us, and it's called a moral injury. So we're embarking on some work on that. That's going to include hopefully thousands of physician interviews and some patient interviews, and we'll come up with some specific policy recommendations, and we'll talk more about that. All of this works into the theme of why we have chosen to advocate for single payer by fighting against Medicare Advantage, because they are, frankly, the epitome of profiteering today. So it's important for everybody to know what Medicare Advantage is and how this works and how it's not really Medicare. So let me take just a moment explaining that. First of all, traditional Medicare, to my way of thinking, is simple, efficient, highly equitable. There's your little red, white, and blue Medicare card that we hold on to for dear life. And it works not quite as simply as this cartoon, but we pay our tax dollars, and then the federal government, we get our card, and then the federal government pays physicians and hospitals and such for care. It's obviously a bit more complex than that cartoon, but in terms of the overall cash flow, that is how it works. It works that simply. Medicare Advantage is completely different. It is completely different. Some would say it's not even Medicare. So rather than Medicare simply paying for the healthcare that we get, Medicare prepays insurance companies supposedly on our behalf. It prepays the insurance companies, and then the insurance companies have their own contracts with physicians and hospitals and such, and they do it like that. So they're prepaid, which means that when they then have to take their dollars that they have in the bank from CMS and pay a doctor or a hospital, that's what they literally call a medical loss. It's actually called a medical loss. It's a term of art from the insurance industry that they've put into healthcare, but they call it a medical loss because it is a loss. They've been prepaid. If they have to actually pay for healthcare, that's their money that they're letting go in their minds, and so they don't want to do that. And part of their strategy, of course, is that they don't let patients go to any doctor or hospital. They say, oh, you can go to this doctor and not that doctor, or this hospital and not that hospital. And traditional Medicare doesn't do that. Traditional Medicare has virtually every hospital in the country, and something on the order of 90% of adult medicine physicians in the country in their network. Medicare Advantage companies play these games to not do that. So many would say Medicare Advantage is actually not really Medicare. And there are actually some bills in Congress that would preclude them from using the word Medicare in their name, because so many of us think that they're really not even Medicare with such a different model. And certainly question to whom the advantage of Medicare Advantage goes. And it's not clear to me that it goes to patients, but they do what those different colored arrows do. They block access to many physicians and hospitals, and they get in the way of healthcare. And what they do permit, they often delay or outright deny. Even if it's covered in theory by Medicare, they still can delay and deny it. Medicare Advantage uses all of the managed care tools like prior authorization and such that delay and deny care, that are almost completely absent from traditional Medicare. Traditional Medicare almost never requires prior authorizations and such. And indeed, what most folks don't realize once they sign up for Medicare Advantage is that they're trapped there. So to be clear, you can always, during open enrollment, migrate back from Medicare Advantage into traditional Medicare. You can be in Medicare Advantage for 25 years and then decide you want to get out and you want to go back to traditional Medicare. And there is no barrier to that, except for one thing. Except for one thing. And that one thing is that you're not assured of being able to purchase Medigap. We already talked about how important it is to have Medigap if you're in traditional Medicare. Like I said, 90% of people in traditional Medicare have Medigap one way or another. Some don't see the need or whatever, can't even don't do it. There are some who don't think it's a good investment, but 90% of people are there. And so most people who are in Medicare Advantage who think about moving back to traditional Medicare would only do that if they knew they could buy Medigap. And here's the thing. They don't have that guarantee. So, the Affordable Care Act, remember that? The Affordable Care Act made it so that insurance companies going through the ACA marketplaces cannot screen you with a health survey questionnaire. They cannot deny you a policy if you have pre-existing conditions. They can't charge you more if you're diabetic. The ACA gave us this guaranteed issue, a community rating of insurance policies through the marketplace. And most people think we solved that problem. Pre-existing conditions is no longer an issue when you go to buy insurance. It's not true once you turn into Medicare. The ACA did not offer those protections to people in Medicare. So prior to the ACA, federal law said that if you are in Medicare Part B, a Medigap insurance company is required to sell you an insurance policy if you apply for one. Without any health survey questionnaires, without any underwriting, and at the same rate as they do anybody else in your community. Hooray. For the first 6 months that you're in Medicare Part B. If you're in Medicare Part B for 7 months, you no longer have that protection, and they don't have to sell you a policy. And that's extended to 12 months if you're in Medicare Advantage. So if you go into Medicare Advantage, or Disadvantage as some call it, if you go into Medicare Advantage, and you're there for more than 12 months, and you then decide you want to go back to traditional Medicare, you might be able to, you can actually absolutely do that, but there's no assurance that you can purchase Medigap. They don't have to sell you a policy, except for 4 states that have made state laws that require them to sell you a policy. But in 46 of the states in the country, you do not have those protections against pre-existing conditions when you're trying to purchase Medigap after 6 months that you're in Medicare Part B or 12 months that you're in Medicare Part C, Medicare Advantage, which means most people in 46 states who are in Medicare Advantage are essentially trapped there and don't have an affordable way to go back that they can rely on. They might be able to do it, but they can't rely on it. And then the last piece, of course, is that the very structure of this means that the Medicare Advantage companies harming people is not on the business plan. It doesn't matter if they harm people. And in fact, what I'm going to show you is that harming us, patients and physicians and hospitals, is intrinsic to how they are to their financial imperatives and how they're structured. So we need to look for a moment. This is the wonkiest part of my presentation, I think. If you don't think that was too wonky, then this is wonkier, but I think this is the roughest part to get through. It's how the finances work in Medicare Advantage. And you need to understand this part if you want to understand the specifics of how they get these subsidies. So when you look at this, what I'm going to show you, you'll probably come to the same conclusion as I do, which is that this is a system you design if you want the insurance companies to be gaming it and maximizing their revenues. I think the people who designed this didn't have that in mind. I think they were noble and really thought they were doing well. But when look at the structure that I'm going to show you and tell me that it's not designed to be gamed. So how much should you pay a Medicare Advantage corporation? How much should they get paid? In traditional Medicare, the Medicare just pays doctors fee for service by a rate schedule or DRGs or what have you. Medicare Advantage is prepaid for you. So how much? How much should Medicare prepay you? And when it was originally set up, it was just set up that they would be prepaid at the average amount for people in traditional Medicare, and then and actually 5% less than the average, because they said that that's how good we are. You can pay us 5% less than the average and we'll make money. And they quickly figured out, oh my gosh, these people are sick. Why didn't you tell us? So there became this whole thing of establishing a benchmark. How much should a Medicare Advantage company be paid for each of the people? And that benchmark is based on the geography, it's based on diagnoses, it's based on a range of things, but it starts indeed, as it used to, with the average cost of people in traditional Medicare. So Medicare establishes the per person benchmark of what the average person in traditional Medicare would cost. And then that benchmark gets adjusted based on how sick the Medicare Advantage firms claim their patients actually are. But there's this benchmark. And then a Medicare Advantage corporation can submit a bid below the CMS benchmark, that this is all that we need. We're only going to spend this much, a smaller amount. And then the MA plan can keep 2/3 of the difference between what the benchmark is and what they've bid. The MA plan can keep 2/3 of that as what's called in the industry a rebate. So you may hear about rebates, and that means a bunch of different things in a bunch of different settings. In Medicare Advantage, the word rebate means the difference between the benchmark and what they have bid that they need. And that difference is called a rebate, and the MA plans are allowed to keep 1/3 of it, or 2/3 of it, roughly, and then another third goes back to CMS. So a win for CMS, in theory. I'll show you that's not the case. And in theory, those rebates that the MA plans get to keep are intended to be used to add in those extra benefits, intended to add in hearing, vision, dentistry, pharmacy. That's what the rebates are intended to do, or to produce the out-of-pocket maximum that's lower than statutorily required. So the rebates are intended, are designed into this model so that the MA plans can have a richer benefit than are in traditional Medicare. And remember, this benchmark is set up in theory to be the average cost in traditional Medicare. And indeed, if the MA plan is able to deliver those benefits for less than the patient would cost in traditional Medicare, then that savings should go into their cost sharing and extra benefits, and make a design that's more attractive to patients, which it is. That's why they're growing. And then everybody wins. Seems reasonable. So the first thing to bear in mind is that there isn't any actual data about how that 2/3 is being used. The MA plans do tell Medicare what range of benefits they're offering. We're offering hearing, we're offering vision, we're offering this, that, or the other thing. They do say that, and there is a theoretical actuarial value if somebody were to use those benefits. So, hooray. But there is no data. The MA corporations do not report how much of those benefits are being used. They don't report how many eyeglasses are being delivered, how many hearing aids. They don't report any of that. So there's no data about what those benefits are actually worth. And so there's no way to assess how much of that rebate is actually getting pumped back into lowering out-of-pocket costs and improving benefits. We don't know. MedPAC says we don't know. There's no information about this. So there's the first set of games, as you can see. The game is to jack the benchmark up higher. I'll show you how they do that. And then the game is to reduce the actual benefits that they have to pay for. If a plan can submit a bid above the CMS benchmark, that's unusual. If they do that, then they do that, and the patients have to pay a premium to make up that difference. That's uncommon. The average Medicare Advantage premium plan is being sold today, 2024, for $18 a month as a premium, compared to about $200 or $250 for a Medigap policy, and another $35 to $50 for a drug benefit. So you can see the economic decision an individual is facing. I can go into Medicare Advantage for $18 a month, or oftentimes for free, or I can stay in traditional Medicare and not have to deal with the prior authorizations and all that stuff. But I got to spend $200 or $250 on a Medigap policy and another $50 on a drug benefit, and then I still don't have eyeglasses or hearing aids or any of those other things. It's pretty clear. That's why our strategy is based on both reducing the overpayments and simultaneously improving the benefit design. So Medicare Advantage corporations have figured out how to game this. They are getting these rebates have more than doubled since 2018. They now get nearly $200 a month in rebates. It's unclear how much value that has to patients because it's not reported. But what is reported is their gross margins. And Kaiser produced this just a couple weeks ago. The current data for 2023 shows that their gross margins in Medicare Advantage dwarf the gross margins for any of these other organizations. And that's why the insurance industry is more and more trying to capture Medicare Advantage business and less interested in traditional employer-based insurance or these other commodities, as you can see here. So the insurance companies are doing quite all right. Quite all right. And so when they push back on our work and say that if their overpayments are cut at all, that they're going to be in big trouble, that's really hard to see when they've got like $2,000 per year that they don't need. In theory, that money those rebates are going to reduce out-of-pocket expenses, but they're less and less going to reduce out-of-pocket expenses. Less and less of the rebate. 2 years ago, 43% of their rebates went to reduce out-of-pocket expenses. And according to MedPAC, this year, it's down to 39% that's going to reduce out-of-pocket expenses. Why is that? Well, out-of-pocket expenses, of course, contribute to the care. So that's less money that the insurance companies have to pay. So reducing out-of-pocket costs means, so not reducing out-of-pocket costs means patients are paying more, insurance companies pay less. So that's nice. But also, when they reduce out-of-pocket costs to care, then people go to get more care. So it's not just the copays that they pay, but if you're going to go get your colonoscopy because you can afford it now because the out-of-pocket costs are lower, well, then you pay the out-of-pocket costs. The insurance company pays for the rest of the procedure. So reducing out-of-pocket costs is the industry term for that is inducing utilization. If you reduce out-of-pocket costs, you induce utilization and then drive up costs for the system. It's a good term of art to know where to come back to it. But basically, the philosophy here is the more they reduce, the more barriers they produce, the more out-of-pocket expenses, the more prior authorizations, the more barriers they produce, then the more profits there are for the Medicare Advantage corporations, and the worse it is for patients. So the last part of this is we'll unpack this just briefly. This is the one that everybody knows about, upcoding, which is the Advantage corporations add more diagnoses and increase their capitation rates. And then that's worth about 20 billion. That's the number we heard bannered about a lot. Favorable selection. This is where they're paid for average patients, but they actually attract the healthiest. If they offer a gym club membership, that's going to attract somebody healthy. It's not going to attract somebody 94 years old, who's bedbound. So favorable selection is worth another $45 billion of how they're being subsidized. Then there's a whole range of benchmarks that are beyond what I can unpack for you today, but there's all these extra bonuses and things that don't add any clear value. And this is where the country has largely agreed. This is the number that MedPAC and various other organizations that look at this, they're now not really saying 20 billion. Congress is seldom saying 20 billion, but most of these organizations are now quoting these numbers: 82, 83, maybe 88 billion, or if you use the high estimates of these numbers, as high as 104 billion. So we have shifted that dialogue, not as far as we would want, because there's this other piece that I called induced utilization, which is really an important piece. So remember, I said that the Medicare Advantage benchmarks are determined by the average usage in traditional Medicare. 90% of people in traditional Medicare have Medigap and have induced utilization. So Medicare Advantage corporations are paid based on a population that has Medigap, but they're not required to deliver the benefits of Medigap. Medigap largely eliminates copays and deductibles. Medicare Advantage companies have copays and deductibles, and they have this $5,000 to $13,000 out-of-pocket maximum. So they're paid as if they're providing the Medigap equivalent, but they are not providing Medigap equivalent. And then that's another $36 billion. That's another 36 billion. So our estimate is that this number is actually 125 to 140 billion, or if you forget induced utilization. Not everybody agrees about the induced utilization piece. But if you leave that off, 88 billion to, I think it's reasonable to say 140 billion. And that's a big number. If If you look at those numbers, here's the 88 to 140 billion. That number, the 140, is more than the sum total of everybody's Medicare Part B premium. Remember, people pay a $200 or so, sometimes more than that, premium to get Medicare Part B. Whether you're in Medicare Advantage or traditional Medicare, you pay that. Almost everybody does. And if you add up those $200 from everybody around the country, Part B premiums are less than what we're overpaying Medicare Advantage. And likewise, the federal part of the drug benefit, or even what it would cost to put in a maximum out of pocket of $5,000, hearing, vision, dental, and all that. So we're wasting money that we could be better deploying. That was our first report. And I would kind of like to pause there, but I don't want to because we've got so much more to get through before we get to the discussion. So let me keep going if you don't mind. The second report talked about the harms that are being done, and I'm not going to unpack these, but there's a whole range of ways that are hurting people. And if you look at our report, you'll see good narratives, anecdotes, some video recordings, and stories, and some sizing of these problems, which is not being disclosed to people when they're making the decision to go into Medicare Advantage. So we think that this range of harm needs to be better communicated to people before they get trapped in traditional Medicare. And I'm going to skip this part because of time. I've been blathering too much. So then our third report is going to be talking about equity, sort of adding up all the things that we're doing. And then we're also working on this report about moral injuries. And we've secured a really amazingly generous grant to work on this from the Robert Wood Johnson Foundation. So that's just barely getting started as a study. Let's go back to strategy, which is, I guess, the topic du jour. I added that other part in because I thought you needed to understand why we're focused on Medicare Advantage, and we can talk more about that. But let's go back to the bigger picture of strategy about this, and specifically, what are the tactics for the next 2 years? And there's a lot, and they focus around a few things. The first is this goal we have of leveling the playing field between traditional Medicare and Medicare Advantage. Medicare Advantage is heavily subsidized, as I hope I persuaded you. And with those subsidies, they're able to offer these extra benefits, or at least the appearance of these extra benefits. And that means that somebody making the decision between traditional Medicare or Medicare Advantage is in a financial trap. And we think that that playing field needs to be leveled. Medicare Advantage companies should be able to promote themselves by what they said they do, which is improving the quality of care. So let them do that. Let them show people that they do that. Let them compete on that rather than competing on being subsidized and being able to do things that traditional Medicare isn't able to do because they don't have the funds. So level the playing field is the theme of a lot of our tactics. And then more specifically, there are a handful of critical moments in time over the next 2 years that we're focused on specific tactics on. And our goal is to use Medicare Advantage as the epitome, the poster child of the insurance industry, but to try to make it clear that it's not just Medicare Advantage. These problems that we're talking about in Medicare Advantage are rife through the insurance industry. All of the employer-based commercial insurance, the Medicaid managed care, the same problems are everywhere, but it's a bowl of spaghetti. So we're focusing on Medicare Advantage, but be aware that the problems are indeed everywhere. So what are these critical moments? The most immediate one is the open enrollment period. Once a year for a couple of months is when people can sign up to go into Medicare Advantage. Plus, when they age in, they can do. But once a year, you can switch from one to the other. And the national narrative around Medicare Advantage every year has been shiny, shiny, new, great. The national narrative, a lot of the media, most of the ads on the TVs are all about how great Medicare Advantage is without any of the issues that we've been talking about, the subsidizations, the pilfering the Medicare trust fund, the harm being done to patients and physicians and hospitals. None of that gets very much media attention. So our intention is to get that narrative to change. For open enrollment 2024, we want that narrative changed, and we know we can do that. We know we can do that. Remember, the narrative around overpayments was $20 billion 2 years ago, and our work, along with the work of our allies, shifted that so that now the narrative is 80 to $140 billion. So we can change that narrative. We know we can do that, and we want to do that around the open enrollment piece. Part of the strategy for that is coming right up on September 30th. So there's a national day of action that PNHP, along with many of our partners, are trying to convene all over the country. And I would recommend at the end of your internship, when you go back to your communities, go back to Louisville and to everywhere else that you know, or your friends that are back in other states, help us reach out and get them aware of this national day of action that we're organizing around the country to draw attention to the hazards and over subsidizations of Medicare Advantage, so people make better decisions. And our plan is to apply those lessons from 2024 into 2025. So we're hoping to get a grant to do a really professional messaging campaign in 2024 that would be structured in a way that we can test the messages and apply science rather than anecdote in 2025. We're hoping to learn things from our campaign for open enrollment in 2024 to make our campaign on open enrollment in 2025 even more effective. Second part of the next critical moment will be in late winter, early spring 2025, the rate adjustments. So this is a huge success story that if you don't know, you need to know and be enormously proud of. So every year, since they've been around, since Medicare Advantage has been around, every year around late winter, early spring, CMS actuaries come up with a number of here's what we think the Medicare Advantage benchmarks and rates should be adjusted by. Because there's inflation and this stuff. So every year the CMS actuaries propose, here's what we're going to pay Medicare Advantage companies over the coming year, over the next year. So they do that using science, fly into politics, science. So they do that. And every year it's egregious. I showed you how high the profits and margins and overpayments are to these corporations. So every year the rate is egregious. That's not the rate that CMS originally proposes. So CMS proposes a number and then as a draft proposal, and then immediately industry descends on CMS and says, oh, no, house on fire. You do that, we're going to have to cut back on grandma's hearing aids. You do that, we're going to do this. We're going to pull out of that market. We're going to do this, that, or the other thing. Oh, no, you can't do that. Don't you know how important this is? It's the solution to equity, which is not true. So every year industry descends on Medicare and says, don't go with that proposal. You've got to go much, much higher. And every year Medicare bows to the political pressure and goes much, much higher. 2 years ago, a small group of advocates, I think really like 3 people, went to Medicare and pleaded with them to hold the line, don't go up, use your actuarially defined numbers, don't cave to the political pressure. 2 years ago, they did that and they started the conversations. Medicare listened and went, yeah, but nobody's got our backs here. We're in a political environment. So 2 years ago, they jacked up their rates beyond what their actuaries said was necessary. Last year, this year, actually, I guess is what I'm trying to say. In spring of 2024, we did a campaign on this. We built on that conversation and we did a campaign. PNHP working with Be a Hero and Social Security Works and Public Citizen and Just Care and People's Action and a few others. I think you met Wendell. He was a help with this. So we did a campaign when we had dozens of meetings. Most actually were led by PNHP members. We had dozens of meetings with members of Congress and congressional staffers. We had, I don't know, thousands and thousands of letters and emails that were sent to members of Congress. We had many op-eds and letters to the editor. We did a campaign saying, hey, Medicare, you put out this scientifically derived number. Use it. Don't bow to political industry pressure and change your rates. And we will be watching you, Medicare. You saw how much noise we made asking you to hold to your rates. Please, please don't get us even angrier. You won't like us when we're mad. Please don't get us even angrier. Please hold to those rates. And this year, 2024, the first time ever, advocacy worked and Medicare held to their draft proposal, despite tons of industry pressure. So, I mean, hooray, huge success. I think we should be really proud of that. They still wound up with a bit of an increase, which they interpret as a decrease, but it's not at all what we want, but it's slowing down the train. It did slow down the train. So we tried in 2023. We had a hugely successful campaign, and next year we want to be even more aggressive and successful with that. And you know that it worked because the insurance company stock prices fell when the final rate proposals came out. Thanks to the advocacy work of PNHP and our allies, the insurance company stock prices fell so industry, it was noticed. The next critical moment, of course, will be when the Medicare for All legislation gets filed. Every 2 years, it's a new Congress, and every 2 years, those bills get resubmitted to the House and the Senate. So that's going to happen again next year. Now we've been assured that it will happen again. And what I would what I would plead with, it seems like some years we really spend a lot of time thinking about, oh, we should add this language to this part of the bill. Oh, we should add that language, and we splinter as a movement around. No, don't bother with that. Yes, bother with this. And we sort of spend a lot of time making, I guess, good but relatively limited changes to the Medicare for All bill every year. And sometimes we splinter over that. And understand the Medicare for All bills need more co-sponsors, but no matter what we do, they're not going to get enacted during the next president, whoever that is likely to be. So, let's not waste time on this part that's not going to actually change anything about moving the ball down the hill. So the strategy that we have for this is let's, fight for co-sponsors, but let's not spend too much time revising it. The Congressional Progressive Caucus has assured us that the Medicare for All bill will be one of the handful of bills that members of Congress have to endorse if they want to be considered a member of the Congressional Progressive Caucus. So they have to endorse, I think, 80% of the bills, something like that, that the CPC identifies. And if they don't endorse that many, then they can't consider them. They can't be identified as a member of the Congressional Progressive Caucus. So having the CPC include our bill is one of the things that they require for membership within the CPC. That's a huge piece that gets us a lot of the way towards getting co-sponsors. And we've been told in writing that we can expect that to be the case for 2025 filings. So yeah, when the bill is filed, we'll again be fighting for more co-sponsors. And then the last and perhaps most interesting but not yet existent bill is this level the playing field bill. It's a level the playing field bill that many of us spent the last 6 months crafting an outline for. So all the same groups that I mentioned to you have been working on this for the last 6 months. It's now in an outline form, and it's being turned into legal language for filing. And we are in the process of having really good conversations with multiple members in the House and Senate, trying to get someone to lock on and sign the bill and co-sponsor it, or file it in the Senate and the House, and so that we can organize around it. And it'll do all these wonderful things. Here's an acronym you probably don't know: the MOOP. It's actually an industry acronym: maximum out of pocket. A maximum out of pocket is called a MOOP. M-O-O-P. MOOP. It's a new one to me the last 6 months. So we looked at a lot of ways to deal with the Medigap issue. Should we have a public Medigap? Should we subsidize the Medigap companies? Well, we didn't want to subsidize Medigap companies. We didn't want to pay for your Medigap in the commercial market, in part because those Medigap companies have outrageous profit margins. They have a 22% profit. So Medicare, operates with a 2% overhead. Medicare Advantage with a 15% overhead overall. Medigap policies have a 22% profit and overhead built in. So yikes, that's not something that we wanted to pump more public money into. So instead, what we thought a way to accomplish the same goal was to give everybody in Medicare $1,000 maximum out of pocket for A and B combined. So our bill that we're proposing has a $1,000 maximum out of pocket for A and B. And if you think about that, that means that most people could go into traditional Medicare and not have to worry about Medigap. And most of the people for whom $1,000 out of pocket maximum is too high probably also qualify for Medicaid if they're in an expansion state. And so they're dual eligibles, as that's called. So we think a $1,000 maximum out of pocket is a pretty good policy if we can get that to be submitted. Um, it's not single payer, right? This bill that we're talking about is not single payer. So the $1,000 out of pocket is outrageously high compared to the zero out of pocket in single payer. But there are many people that we're trying to collaborate with who buy into the notion of skin in the game, of, they like the idea of some degree of copays and such. So we're not asking for a zero. We're asking for a $1,000 maximum out of pocket for A and B combined. That's, to me, the most important part of leveling the playing field. It eliminates the need to buy Medigap. So that's the most important piece. But also add in the bill that we're proposing adds in hearing and vision and dental, and even a pretty cool strategy for pharmacy. So add in the missing benefits and fund it in large part by ending those subsidies. And we have a lot of detail around that. And then the bill also has a number of other changes to this, to how this whole thing is structured, that we think would benefit everybody, be they in any form of flavor of Medicare. So I'm not going to unpack that today, but there's that bill that if we do get it dropped sometime in the next few weeks, hopefully this summer for sure, you'll hear more about it. We're calling it level the playing field. I don't know if that'll be the final name. And then, of course, we're trying to think through what all this means based on the national elections and, who might or might not, or what might or might not happen. And understand PNHP is a nonprofit, nonpartisan. We don't pick sides. We don't advocate for or against anybody in Congress or any elected official or party. But still, we can make sure people know what kind of decisions are on the table and are being considered. So trying to figure that all out. So, like I said, we don't have the power to get to single payer today, and we won't have that power with almost anybody who could be president coming up. But that remains our target, right? That is our organization's reason to exist. And so, how do we build our power so that we can get closer to that? Grow our membership. We have, as you probably have heard, we have 26,000 members, mostly physicians, some med students, a lot of med students, and a few other folks. There's 1 million doctors in the country, right? There's 900,000 doctors in the country. So 26,000, that's a lot, hooray for us, but that's like nowhere near enough. And we know that the majority of the physicians in the country agree with us. So 60% is a number that maybe you can say. So we should have hundreds of thousands of members. We've got 26,000 because we've never really focused on that. We were build it and they'll come. Well, no, we got to do more than that. So we have a range of strategies around growing our membership so that we have more power. If we had anywhere near what we should have, this we would be done. And part of the structure, part of our power comes through our chapters. So we have chapters in almost every state. So we want to, get more of them, and we want to do a lot more to support them. We have a number of pieces afoot for that. The Students for a National Health Program, SNAP, is a vital part of this. We've been reaping the benefits of SNAP now that it's got some maturity to it. Where members of Congress have their legislative aides. Some of them have been SNAP graduates. I mean, how cool is that? SNAP trained people who are now legislative aides in Congress. That's like awesome, and doing all sorts of leadership stuff. And so SNAP, it's critical part of the road to the future. Fundraising, nobody wants to talk about fundraising, but got to do it if you want to pay for the extra staff. We've been fortunate to be able to get some success on here now that we're focusing on that. We've expanded our staff a little bit, which means we can do more of the growing SNAP and growing our chapters. These things are intertwined. We've always had some relationships with adjacent organizations, and we are strengthening them much more so. We're now meeting at least every other week with most of them, with lots of them. And so it's like much stronger, much more able to collaborate and coordinate messages. And we have a campaign that we've been embarking on to get medical societies more on board. The pediatric group, actually, the senior section, I didn't know there was one, but the senior section of the pediatric American Academy of Pediatrics has been very vibrant. The American Academy of Family Physicians has been. The American College of Physicians has had some work going on, and there have been presentations and neurosurgical meetings. I mean, we've been trying to penetrate more into that, and certainly into the AMA. And SNAP has been heroic at some of the AMA work. A little beyond scope to talk about that today, but SNAP has been terrific at AMA work. Then lastly, we believe this moral injury report will resonate really widely with physicians around the country, and give us opportunity to get our messaging out to talk about how we are offering you a place to raise your voice about these injuries and a solution to them. So that's sort of a core of what we're doing. So we're kind of trying to take the spaghetti and find a piece to eat rather than eat the whole thing. That was a lot to talk. Give me 1 second. Okay. Was that clear? That was a lot of stuff. The floor is yours, interns. What's on your mind?